So this chapter, we're going to go over infective endocarditis. Previously, it was referred to as bacterial endocarditis, or BE, but it's not just bacteria that can cause endocarditis. It's many things like viruses, fungal infections. Although it's fairly uncommon, it is a disease that mainly affects our cardiac valves, which can cause many different heart issues, including heart failure. So we do want to determine if somebody does have IE. Bacterial endocarditis is not the end of the world because we have lots of fabulous antibiotics that can help fight that infection. It is a little bit more difficult to treat when patients have IE due to a fungal or viral infection. Although IE tends to happen or occur in patients with underlying cardiac comorbidities such as valvular heart disease, IV drug abuse. We'll go through the risk factors. Most of the time it occurs in patients with those risk factors, and sometimes very few can occur without any, cause or, a really big picture of risk factors. So pathophys-wise, it occurs when blood turbulence within the heart allows whatever organism, whether it be bacterial, fungal, or viral, to infect either previously damaged valves or the endothelial surfaces within the heart. So if we compare this to like hypertension, hypertension can affect our innermost lining of our vasculature. It's kind of the same analogy with IE. This is just a picture of the endocardium, and as you can see, those valves are part of the endocardium. So IE can be classified based on the cause, such as IV drug abuse, or the site of involvement if somebody has a, aortic prosthetic valve. So that's how we kind of classify IE. There are many different risk factors to infective endocarditis, including cardiac risk factors such as prosthetic valves, non-cardiac reasons such as IV drug abuse, and then procedural reasons such as renal dialysis, because we have those invasive ports, or the use of intravascular devices, specifically central lines. Age is also a risk factor, and once upon a time, before we had those fabulous antibiotics, rheumatic heart disease was actually the #1 risk factor for IE. And rheumatic heart disease stems from untreated strep throat that can lead to heart failure and other complications. One of the primary clinical symptoms of IE is vegetation. And whenever I hear this term, I don't know who makes up this terminology, but I think of a vegetable garden, and that is not what this is. So with endocarditis, clumps of bacteria or viral clumps and cell fragments actually form in the heart at the site of infection. And these clumps of fibrin, leukocytes, platelets, microbes, all of those things are called vegetation. So it's actually this like buildup of nastiness that grows on that cardiac valve or on the endocardium. Most commonly, it does go on the valve. So just a little bit of information about our cardiac valves. So we actually do not have very good blood supply to our cardiac valve. So it's very difficult to fight infection for blood flow to get to our cardiac valves. So heart valves are not directly supplied with blood. So it's very difficult for them to fight infection or for infection to be fought at that site. So that's primarily why these valves are so affected. Like why are the valves so important? Because we don't really have the mechanisms in place to kind of, fight this off. One of the other really crappy things about this vegetation is parts of those clumps can actually break off and enter circulation as little microemboli. So some of the clinical symptoms that we get can be entirely systemic because little pieces of those microemboli can break off and, let's say, get clogged in our kidney and cause some sort of kidney impairment. We'll go through more specifically, but just to have in the back of your mind. So not only is it this vegetation that's directly affecting the heart, but then we get these little pieces of vegetation that can break off entering circulation and cause other systemic problems. So let's look more specifically at some of the clinical manifestations that are common with IE. So the clinical manifestations of IE are very nonspecific and generalized. It can, again, involve many of the organ systems, which we'll get into in just a second. Mainly a low-grade fever occurs in 90% of the patients. So more about those non-specific type symptoms or clinical manifestations are the chills, weakness, malaise, fatigue, anorexia that can be seen with many other different types of disease processes. Some other clinical manifestations that can be present are arthralgias or joint pain, myalgias, which is muscle pain, back pain, abdominal discomfort, weight loss, probably primarily from the anorexia, headache, and clubbing of fingers can occur. And many of these are because of those microemboli that break off, right? I could get back pain if those little pieces of microemboli from the vegetation break off and, affect my kidneys. That can cause back pain. So more specific to IE are these vascular manifestations. So some of these include splinter hemorrhages in the nail beds, and these are black streaks that happen in your nail bed. So if you ever hit your nail really hard against something, or your finger got squeezed in something, you know how you have these black lines that occur just in your nail beds? Those are splinter hemorrhages. So those can occur, and that's because there's little pieces of microemboli clogging up those small capillaries and causing necrosis, basically little areas. Petechiae can occur, again, from microemboli. Usually those petechiae happen in the periphery. So we will see petechiae in, let's say, our hands, our feet. It's very unlikely for you to get petechiae over larger body parts like our abdomen. So it's usually in the periphery that our petechiae wind up being present. Then we have these Osler's nodes, Janesway lesions, and Roth spots. So Osler's nodes are these very painful, tender, pea-sized lesions that can be found on the fingertips or toes. And again, that's due from those microemboli pieces. Janesway lesions are flat, painless, small little red spots that occur on the palms or soles of the feet. And then Roth spots can only be seen with an eye exam by an ophthalmologist. They're retinal lesions. They're little areas of petechiae or areas that have been affected by those microemboli, and those are called Roth spots. So you wouldn't be able to see those looking at a patient. They would need an eye exam to be able to visualize those. So you might not be able to see the right side of this, but these are just an example of the Osler's nodes. So they're very subtle, but they are these painful, tender, pea-sized lesions that are found on the fingertips or the toes, as you can see here. So you really wouldn't notice them unless you were looking, really. Same with Janesway lesions or Janeway lesions. These are flat and painless, so they're not raised up like the Osler's nodes are, but these are also seen on the palms and soles of the feet and are very specific to IE. Some of the other clinical manifestations include a murmur in most of the patients, either a new or changing murmur, so a murmur that hasn't been there, or if it sounds different. The aortic and mitral valves are the valves that are most commonly affected. Many patients with IE will present with signs of heart failure, especially left-sided heart failure, since the aortic and mitral valves are the most commonly affected. Other manifestations secondary to embolism, those little microthrombi or microemboli that are formed from the vegetation. So if those little pieces of emboli wind up in my kidneys, some of the symptoms I would have is left upper quadrant pain or tenderness. For my kidneys, I could have hematuria or potentially renal failure, or some degree, maybe not complete renal failure, but some changes in my kidney function tests. Our limbs, I could actually wind up with ischemia or gangrene, depending on how big or how much emboli is thrown. Usually it's from dislodgement or lodgement of those emboli in smaller blood vessels. For the brain, I would have symptoms of a stroke, so aphasia, ataxia, change in level of consciousness, visual changes, hemiplegia. For our lungs, these would be the same symptoms I would have for a pulmonary emboli, so dyspnea, chest pain, hemoptysis. So lots of other things to think about with IE. It's not just the cardiac symptoms, but because of that vegetation, we can wind up with microemboli going to other areas of our body and causing different kinds of symptoms. IE occurs mainly because we have an infection in our bloodstream that then gets kind of clogged or gets latched onto our valves, our damaged valves, or a damaged endocardium. So gathering a history of recent dental procedures, IV device placement, any dirty procedures such as urological, gynecological procedures, any recent cardiac caths, anything that could potentially introduce bacteria or some sort of infection into the bloodstream. We say dental because our mouths are disgusting. We have a lot of bacteria in our mouths, and if we have dental procedures, we can have some of that bacteria get into our bloodstream if we have bleeding gums or something along those lines. So dental procedures are often things that we don't think of much, but that puts us at a risk for IE. So gathering a very detailed history is important. So in order to diagnose IE, there needs to be vegetation that is seen via an echo, and we see this via a TEE. Generally, a regular echocardiogram, we cannot see if there's vegetation, so they will go down for a transesophageal echo or a TEE to determine or rule out if there's vegetation. So we need either vegetation on an echo via a TEE, we need a new or changing heart murmur, and or positive blood cultures. So there's three things: positive blood cultures, vegetation, new or changing heart murmur. And you need 2 out of those 3 to be positive to rule in a diagnosis of IE. Clearly we don't diagnose, but it's important that we know or to look for these things. So our lab tests, since blood cultures are one of our diagnostic criteria or a piece of the puzzle, we would obtain blood cultures. So blood cultures need to be drawn 30 minutes apart from 2 different sites. Depending on the bacteria that is growing, sometimes it can take a while for bacteria to grow, or very slow growing bacteria. So cultures are kept for quite a long time. Our CBC with differential, we would be able to see a leukocytosis if somebody had an infection. ESR and our CRP are our inflammatory markers. Those would be elevated. If somebody had IE, we would expect that. And then our TEE to detect vegetation. Chest x-ray, we could see if there's any cardiomegaly, or we could even see if there is a lung infection that could potentially be the cause of our IE. ECG could show some electrical disturbances if our valves have been affected. And then a cardiac catheterization, we can evaluate the lab functioning, and we could also see if coronary arteries have been involved. And if somebody needed a valve replacement or some sort of surgical intervention to fix the IE or to fix that valve, we would want to make sure that those coronary arteries were clear before undergoing any surgery. So a select group of patients who are at high risk for IE, or for those patients who have had IE in the past, or who have had prosthetic heart valves, congenital heart defects, or a cardiac transplant, there are certain patients that are at very high risk for IE, like I just said, and they require prophylactic antibiotics before certain procedures to protect them against IE. For example, if I had a valve, a prosthetic heart valve, and I was going in for a tonsillectomy and adenoidectomy, I would receive special prophylactic antibiotics because I am at high risk for IE just because I have a prosthetic heart valve, just for an example. Your book does a really good job. If you look under this chapter, there's boxes that will tell you, people that are it's necessary to provide them with prophylactic antibiotics, and then it will also give you those procedures that are pretty high risk. So because our cardiac valves do not have stellar blood flow to them, treatment for IE is long-term. It requires 4 to 6 weeks of IV antibiotics in order to kill the bacteria. So it's really important to accurately identify the organism since it's a really prolonged use of antibiotics. Repeating blood cultures to make sure that the antibiotics are working, to make sure that we don't develop resistance to the antibiotics. For those that have either fungal or viral IE, valve replacements are pretty common just because we're unable to treat. We don't have a lot of antivirals or antifungals that adequately treat IE. Some of the other things that we need to consider, antipyretics, especially if there's a fever. And remember, one of our prominent symptoms is 90% of patients or greater will have some sort of a fever. And usually the fever, generally we say that once patients are started on antibiotics, usually their fever subsides within 24 hours. That is not the case for IE. A lot of patients will have a fever for a couple days, even after antibiotic treatment. So the usual Tylenol is fine for that. Lots of fluids, unless it's contraindicated if they're in heart failure. But in general, we would push fluids. And then rest, not necessarily bed rest, but we do want to make sure that they are taking care of their heart and preventing against those heart failure symptoms. It's not uncommon for patients to be on more than one antibiotic just because relapses are so common. It's common that the IE will come back. Some bacteria can lay dormant for a while, unfortunately, so that's why such the prolonged period of antibiotic use. And why you're at such a great risk if you've already had IE in the past. So for our subjective data with our health history, some of the things that we would want to obtain is if they have a history of IV drug abuse, if they have alcohol abuse, have they had a previous history of IE? Do they have any congenital cardiac disease? Do they have valvular heart disease? Are they immunocompromised because of medications that they're taking or because of certain conditions that they have? And then, like we said before, if they've had any recent surgeries or other treatments that put them at high risk. And then we want to see about their symptoms. So then we would ask them about weight changes because that would direct us toward heart failure. Chills and anorexia, which are the symptoms. Hematuria from those emboli going into our kidneys, and so forth. And the rest of the symptoms are also related to those microemboli that can break off. Night sweats from the fever that are fairly common. And again, assessing for heart failure or the degree of heart failure if they are in it. And again, some of the objective data, are they running a fever? Because it's present in most cases. Checking their extremities for those Osler's nodes, the Janesway lesions or splinter hemorrhages, which we talked about on the previous slide. Our petechiae or purpura, which are present in our extremities. Again, it is not common for the petechiae or the purpura to be present like on our trunk or on our shoulders. It's more commonly present on like our feet, our hands, even like on our lips, anything that's peripheral or really surfaced. And then the rest of the 3 bullets, sorry, because the retinal hemorrhages are those Roth spots, but the 3 bullets for the peripheral edema down to the dysrhythmias would be from our valve dysfunction, and then possibly because we have valve dysfunction causing some degree of heart failure. So those symptoms are related to that. So our main goals for patients with IE is to ensure that they have normal cardiac function. We don't want them to have any degree of heart failure because that valve is not functioning appropriately. We want them to be able to perform ADLs without fatigue, or at least at their baseline. And most importantly, wink, wink, we want to make sure that they understand their therapeutic regimen to prevent reoccurrence. So there's a lot of education that needs to be done with these patients. We need to ensure that they complete their full course of antibiotics, that they're compliant with their antibiotics because they're IV, and that they follow up with their provider and make sure that they get those prophylactic antibiotics that they need to prevent reoccurrence from IE. Because once you already have IE, that puts you at risk, to get it again. So again, we just want to decrease the incidence of IE or prevent reoccurrence in patients who already have it. So identifying those at risk to prevent it, assessing history and the understanding of the disease process to help prevent it or prevent reoccurrence, and then again, really teaching the importance. It's probably one of the most important things is compliance. So other important areas of teaching is stressing the need to avoid infectious people, which we are all doing right now, right? So cold, flu, any sort of respiratory infections really need to be avoided. Rest, so avoidance of stress and fatigue. That's why rest is so important. Really avoiding excessive fatigue. If they are exercising, plan for rest periods, and we really don't want to do any strenuous exercise. I'm talking about going for a walk. Oral hygiene, so not just our regular hygiene, but oral hygiene is so important in regular dental visits because our mouths are gross no matter how much gum you chew, like me, how much you brush your teeth. We just have lots of bacteria in our mouths that we don't want in our blood system and latching onto our destructed cardiac valves. And then our prophylactic antibiotics before certain procedures, and then drug rehab would be something that we would need to encourage for those with IV drug abuse, especially those dirty needles. So home care, clearly patients aren't going to be in the hospital for 4 to 6 weeks to receive antibiotics. They will be at home. So these are IV antibiotics. So here's the problem with this, keeping that line clean. And how about those patients who have IE because they had a history of IV drug abuse? Sometimes that can be a little bit more difficult to treat. It's unlikely that we'll send them home with a central line because we don't want them to have easy access to, administer their medications. So they might have to come to an infusion center every day or have somebody go to their house. So that can be a little bit tricky with that. So for antibiotics, just a review, so we always want to get our blood cultures prior to starting antibiotics. So we would get blood cultures, start antibiotics, and antibiotics are prescribed based on the likelihood of the infectious organism. For instance, if I just had a GI procedure, doctors and providers could kind of hypothesize about the most common organism that could be infecting that patient, if that makes sense. Like we have, if you took microbiology, which all of you did, we have certain groups of bacteria that are more common in different parts of our body. So depending on what caused that IE, they could kind of hypothesize. So anywho, then we would get the blood cultures back, and then they could change the antibiotics based on those blood cultures. But we don't wait to start antibiotics until the results of the blood cultures are back. We would start antibiotics right after we got those blood cultures. Then we would need repeat blood cultures after treatment or if they respiked a fever. So fevers are expected for the first few days of therapy, but let's say I was fever-free and then I am 3 weeks into my IV antibiotic therapy and I start spiking a new fever. That would prompt me to call my provider and get repeat blood cultures to see if A, I have a resistant bacteria, or B, if there's a change in, I need a change in antibiotic therapy. So there's a lot of follow-up that needs to be done. Assessing home care setting to see if there's nursing care that's needed at home, especially managing a central line. Monitoring lab data, again, just to determine the effectiveness of our antibiotic therapy, and then coping strategies to prevent against excessive fatigue. Other things that we should probably talk about too is if you've ever been on prolonged antibiotic therapy, you know that it's not pleasant to your GI system or even to like your skin. There's a lot of sensitivities out there to antibiotics. So helping patients manage those symptoms as well. It can cause diarrhea, itching, rashes. So really kind of keeping on top of side effects of those antibiotics. Probiotics are necessary and very common just to help prevent against C. diff, which can happen with prolonged, especially IV antibiotics. We don't want to kill that good flora in our GI tract, leading to C. diff. So just some things that we need to be aware of, monitoring for adverse reactions to those antibiotics. Other considerations for ambulatory and home care. These are some activities that can be done to prevent against complications relating to resting, right? I mean, if we're sick and we really need to take it easy, we want to make sure that we're not getting a pneumonia or a DVT related to decreased activity. And we also don't want to get deconditioned. So range of motion, exercises, moderate activities such as walking are really to prevent against further complications. And again, for more specific on patient teaching as well, monitoring their body temperature. So they should notice that they are afebrile maybe like several days into antibiotic therapy. So it won't be within 24 hours like a normally. And then if they start to feel like they have a fever again, to make sure that they call the doctor. If they have a persistent fever, if that fever doesn't break, it's like week 2 of therapy and they still have a fever, that's also maybe an indication that they are not on the correct antibiotic. Signs and symptoms of complications specifically from those microemboli. So stroke-like symptoms, hematuria. Do they notice that they have little petechiae or little bumps in the soles of the palms of their hands? So really talking about complications and assessing those for complications. Reducing the risk of reinfection, that would be to make sure they take prophylactic antibiotics prior to any specific procedure. And telling them that now you're at risk for having IE again. So it's really important to, have good follow-up care and early treatment of common infections. That way it doesn't lead to a blood infection and then therefore infective endocarditis again. And then, like I said before, the need for that prophylactic antibiotic therapy.